2021, and looking at it in the way it has now been reframed to have relevance to the current COVID-19 pandemic. And these are my disclosures, and this is the latest document, the Gold 2021. Now, every year, the Gold document, the document for COPD, is modified, is improved. And what has changed, therefore, in consideration of the pandemic? Well, let's go step by step, and later on, I will focus on the specifically in the changes in making a diagnosis, the challenges that go with it in terms of COPD diagnosis. So let me start with number one here in my list: goals of treatment. In the treatment of stable COPD, we have two specific goals: reducing symptoms and reducing risk. And yet those are still the things we strive for, we treat the patient for, and there is no change in these goals. Now, to implement this, it's still bronchodilators. Bronchodilators is the mainstay in COPD attainment of reduction of symptoms and reduction of exacerbation risk in the future. Okay, whether it's a combination of a long-acting or mono or dual bronchodilator. Now, of course, we have also the guidelines mentioning inhaled corticosteroids. Now, I'd like to put this into perspective. By and large, up to today, a lot of patients are still on ICS, like a majority, when in fact ICS has been declared even before the pandemic to be useful in a limited number of cases. And here I have the reiteration of the table that appeared a year before on the factors to consider when initiating ICS as part of the inhalational therapy treatment of COPD. There is strong support for the use of ICS when the subject has a history of a bad exacerbation, like the one requiring hospitalization, or more than one exacerbation, despite bronchodilator therapy. Fine, you can use corticosteroids. Or if the eosinophil count is quite high, we have the parameter now, a biomarker of more than 300 cells per microliter, okay, of blood eosinophil. So the total WBC times the percent eosinophil gives you this count. If you have more than 300, then you probably should use corticosteroid, but still interpreted in the background of the patient, the clinical background of the patient, which I will express also later. And also, if you have a case of COPD with a current asthma suspect, like it's not exempted, an exemption for COPD to have also asthma. So if you have that history on top of the COPD, fine. This patient will probably need ICS on top of the bronchodilators, on top of the dual bronchodilators. So if you have those, then use steroids. And even consider ICS also when there is even a single moderate exacerbation in the past year, or blood eosinophil count of 100 to 300. Now, again, this is now interpreted clinically. And so when you have the green and the yellow boxes there, so you may use here. If you don't have them, you probably should not use, because the data show that you don't get anywhere into additional benefit, but you'd rather have the possibility of side effects. In fact, if patients already have pneumonia, which is a side effect of prolonged corticosteroid use, and now they have pneumonia, then you probably should not, repeated pneumonia, you probably should not be using ICS in this patient. Because as you very well know, the airways in COPD will not normalize with corticosteroids, unlike the airways of asthma. So in asthma, you give corticosteroid. In COPD, you be cautious because the denuded airways are probably colonized, and you just report more pneumonias happening in this patient. And if the eosinophil is low, maybe you should not use it. And if there's a history of mycobacterial infection, in the Philippines, we have it as a very prevalent condition, tuberculosis, and you have to watch out for its presence, especially if you start considering ICS. Okay, so this is the role of ICS now. Now, number 4 here in my list is that blood eosinophilia, therefore, and ICS, no changes in the recommendation. 2021 from 2020. Okay, so there should be the count of eosinophils as well as an estimate made clinically, okay, and assess likelihood of a positive response to the ICS. Now, if ICS is not used or recommended, but already being used, which I was alluding to earlier, then the document includes still the recommendation to withdraw the ICS. And there's no change in this, and we can discuss this later. Now, in the market now, we'll be having triple therapy, meaning LABA, LAMA, ICS on board. It's very convenient because the three are together. But since we have this caution in the use of ICS, or in specific situations you don't really have to use ICS, then we have to be applying this triple therapy judiciously to those who do not, who will benefit from ICS. So there is no change in that situation from the previous recommendation. The caution is still there. Number 7 in my list is inhaled therapy. There's no change to the previous recommendation that the treatment that worked before, and these are usually in inhaled drugs, the LABA, the LAMA, and even the ICS if necessary. If they are effective, they are needed in the patient before COVID, they will still be continued during COVID. And then number 8 here is the management of stable COPD. We have the recommendations before, we continue it now. The recommendations before also said that we have to sort out the asthmatics, because then you can have your steroids in the asthmatics, but you don't do that in the non-asthmatics, and also in those who are not exacerbating, as I will show in the next slide. And in the management of COPD, you have to have a correct diagnosis based on the symptoms. And before we use spirometry, this is a challenge now because we cannot just do aerosol generating procedures. Okay, so we'll talk about this later. But then we should have a diagnosis, and then we have the initial treatment based on the symptoms and the exacerbation history of the patient. I will show that the quadrants, and then the initial management. And based on the response of the initial management, we look if the patient is okay, smiling, controlled, or the patient has still symptoms, or actually having exacerbation, or both. So that's still there in the new guidelines. Now, here's the treatment recommendation in the capsule. If you are starting a patient with COPD with treatment, and I'm sure you are familiar with this, okay? And so we group them together as to the presence of symptoms. So this line here would be symptoms, more symptoms. And then horizontally into the tendency of having exacerbation. So if they are not so symptomatic and less or few exacerbation or no exacerbation, they belong to group A, where they're given bronchodilator. If they are symptomatic but not exacerbating, then they are in group B. And the recommendation here is a long-acting bronchodilator, LABA or LAMA. Right? This is one area actually in the quadrant that may change in the future, because we now find we have data that LABA plus LAMA is actually better than its component. Okay, and then if you have an exacerbating group but one has few symptoms, they're given LAMA, and those are the more severe type of COPD with both increased exacerbation tendency as well as they are symptomatic, they are given the combinations shown above, LAMA or LAMA-LABA, or even ICS and LAMA. Okay, so once they are diagnosed and treated like this, then they are followed up. And now you follow this table. And based on their manifestations, you are guided in this figure that appeared again in the 2021 guidelines. So if the patient is perfect with the initial treatment, then probably just continue the initial. However, if the patient has still symptoms like dyspnea, okay, and they are on a LABA or LAMA initially, say for example, they are in one of these quadrant here, but they're still dyspneic, then the two are combined, LABA plus LAMA. Okay, and if they are still problematic in terms of the dyspnea, but they are not exacerbating, they are just more dyspneic, maybe you consider like the patient may not be able to use the inhaler very well, so you choose to another device, or maybe another molecule, or investigate maybe there's something there outside of the treatment, like a comorbidity that is making it making the patient having dyspnea not exacerbating from COPD, that may require other medications. Okay. Now, however, if the patient comes back to you still with exacerbation, okay, and for example, they were on a LABA or a LAMA, the next thing to do is to give the combination still, LABA plus LAMA. And if they are uncontrolled, there's an option to add an ICS. Okay, if there is a history that suggests asthma or a stigmata of Th2 disease like rhinitis and atopy, and then you you see how the patient will behave if you add that one, or if you are sure there is no inkling of say asthmatic phenotype in the COPD patient, you may actually add other agents like the flumilast, especially if you have a lot of phlegm, chronic bronchitic, the smokers, okay, and also even azithromycin, rather than go to corticosteroid in this patient, because for example, in those with repeated infection, they probably would be better given long-term azithromycin, half the dose for weeks and months, rather than ICS, because ICS might actually worsen the occurrence of pneumonia. Okay. Now, if this patient was on LABA ICS here, and even in the other side, in their dyspnea, as I mentioned, there a good number of these patients actually are using LABA ICS, a spillover to the practice of giving LABA ICS in asthma, which is, by the way, very good for asthma, but not really in COPD. Then there should be an attempt to actually withdraw the ICS if you don't have, again, the stigmata of allergic situation or asthmatic situation. Okay, so these things are still there, and you can download the guidelines. You can review this again. Okay, so therefore, what changed? Well, there are a few that changed. Okay, one is that in addition to taking their regular medication, and by the way, now for airway disease, we always have the choice or the need to give the medication by inhaler, because that will give the medicine straight to where it's needed, saving the patient say waiting or lag phase or even toxicity, because you don't need very high doses. But then one way of giving medicine to the airway is nebulization. But now because of the propensity to actually spill out aerosol generating procedures like nebulization are to be avoided. And we do have inhalers now that can actually substitute very well the efficacy of a nebulizer without that propensity to spreading the COVID virus with the aerosols. Okay, so continue the management that is working. Continue the management that was recommended. Okay, and this will not have to be changed just because there is COVID or there's fear of having COVID. Okay, now if you look at statistics, okay, what is the risk of COVID-19 related deaths in COPD or asthma patients prescribed corticosteroids? So if you have, in COVID, we use corticosteroid, systemic corticosteroid in COVID patients with inflammatory manifestation, meaning severe COVID. But we also found in the recovery trial, in the big trials of corticosteroid in COPD, that giving corticosteroid early, before the inflammatory cytokines actually get into a storm situation, can actually be harmful. So there are no clinical data actually among COPD or even asthma that giving ICS just because there is a worry about COVID or there may be starting COVID, you have to give already corticosteroid in ICU. It doesn't work. Doesn't work. So it's not protective. ICS is not protective. And even in some situations, there is a report of higher mortality in those on steroid. But of course, we don't know because the steroid given in this COPD or even in high dose steroid for asthma may be a marker of really a worse situation, and the COVID was just on top of it. So there is a compounding effect. But by and large, when you have the specter of COVID in an asthmatic or COPD, we just do not change the management by adding corticosteroid, inhaled corticosteroid, because it doesn't protect. Okay, now on the issue of spirometry, this is the problem because through the years we have always advocated for the use of spirometry among our COPD patients to confirm one, the presence of obstructive lung disease, have confirmed reversibility in a way trying to differentiate asthma and COPD among other things. But nowadays, because of the danger of spreading COVID in COPD with concurrent COVID, it can be asymptomatic. They may not have fever. They may just come in for COPD symptoms, and yet they have COVID. They can spread during the spirometry. This is now avoided. Okay, so we go by other manifestations of the patient. However, if the patient has to undergo resectional surgery, we really have to make it out. Then they are done the test in strict conditions like PPE, everybody in the lab, laminar flow, those things should be enforced. Okay. Now, if you really are hard put whether this is COPD or heart failure and so on, and you really have to know that the result of the spirometry. Again, you may have to do it in that specific situation, in that particular case, with all the preventive efforts for aerosol spread. Otherwise, we don't do spirometry. Okay, now we have in the new guidelines a new sentence added highlighting the superiority of LABA plus LAMA over LAMA alone in patients without ICS treatment. So that's something that permeates into clinical practice. And in terms of vaccination, okay, on top of the pneumococcal vaccine and the flu vaccine, the CDC actually recommended, and it's now cited in the guidelines, the diphtheria, pertussis, and tetanus vaccine among those who are not vaccinated in adolescents. Now, there's a new sentence that has been added to highlight the reduced efficacy of ICS in active smokers. Okay, so for COPD patients, have heavy or current smokers do not have the same effects from ICS use in lung function and exacerbation rates compared to light smokers. So we have to keep it in mind that there are markers in the patient that will tell us whether they respond to one treatment or not. This particular point here of ICS use. Okay, and this has been, and now we go to the triple treatment. As I mentioned, these are the inhalers that are coming into the market very soon. Okay, and while we have seen that ICS plus LABA is better than just ICS alone or LABA alone in reducing exacerbation of COPD. Okay, by and large, you can control most of that with the LABA, LAMA without ICS, and of course with the other factors present. Well and fine if you have high eosinophils or high exacerbation, you can add ICS to the combination. Okay, just make sure that you understand what you are getting into, because ICS alone can increase the chance of having pneumonia, particularly in those with some airway changes like bronchiectasis already, because of the severe COPD, they can really go into repeated infection with ICS. So uh, it's important that we have the triple therapy, because there is a place for it, but it's probably not the first option all the time, because as I mentioned, there are just situations where you don't want the third in the triple combination. You don't want the steroid. Now, so let me review the key points in the guidelines. Okay, by and large, the changes are minor. Usually, the guidelines show some really huge effects. Okay, significant effects after say 5 years, and so yearly they may have additional points based on available data. And so in the new 2021, most of the changes are minor, other than specific citations for COVID. Okay, and again, it has been restated that LAMA are the better way of handling the obstructive disease, better than monotherapy. Okay, and the use of ICS-based therapies is predominantly recommended to the reduction of exacerbation, as mentioned earlier. And this risk should be closely watched out if the steroid is not really indicated, because it came, for example, as a spillover use before, then the escalation is possible with the optimized combination of LABA. Triple therapy can provide benefits over LAMA-LABA or LAMA-ICS, but it is never recommended for first-line maintenance treatment. Okay. Blood eosinophils are maintained as biomarker in conjunction with clinical assessment for response to ICS therapy, as mentioned before. Now, let me just end with the reference of the GOLD guidelines to the package of essential non-communicable disease intervention provided by WHO. And here it's very important, because this is, I suggest you also download this document because it really addresses the practice, actual practice in the clinics, that of the primary care, how to assess patients, say somebody with chronic lung disease, looks like obstructive lung disease because the breathing is prolonged exhalation and those things, wheezing and so on. How do you differentiate the asthmatics from the non-asthmatic COPD? Okay, they are all there. For example, in the asthma is more likely if there was asthma in the past. Okay, they say once asthmatic, always asthmatic. Okay, or there's again the TH2 stigmata like hay fever, eczema, allergies, and that as in asthma you really have situations where something is completely asymptomatic. An asthmatic control can wheel down lymphates. That cannot happen in a COPD, because even if they are feeling better, they will always have problems when they exert a lot of effort. Okay, the symptom is worse in the early morning and triggered by infection or change in the weather. And if they are given bronchodilator, beta agonists, they respond quickly. It's just like a lung function test. Okay, so those speak of asthma. But again, if you have somebody else older, heavy smoker, okay, and or exposed to biomass fuel like use of firewood in cooking for many years, okay, and it's gradually worsening, and you have phlegm and frequent infection, in fact, and every day there will always be symptoms. Okay, so some of them actually try to limit symptoms by staying put. Okay, then you consider COPD rather than asthma. And this document has other things there that can help us handle this patient, including remote management of this patient, because we cannot be seeing patients face to face as easily now than before. And you have something like an action plan here that is being recommended. I suggest you look at it because it helps you manage the patient by way of making the patient actually list down what they are feeling, what are the symptoms, what are the medicines they have, and you can also advise what they have to do. Okay, and it also in the gold guidelines we have the other things that can be useful in determining how symptomatic the patient is. This is the CAP assessment that can be filled up by the patient. There are several domains like cough, phlegm, and effective walking, and so on. And they make a score, and the higher the score, the more symptomatic they are. Cut off is 10 and above. Okay, and a more simplified one that is just like walking up the hill and so on, like that can give you a classification that will be useful for the 4 quadrants that I mentioned before. And it's there. This is the Codigo for assessing patients with symptoms. So, Gina, I'd like to end here with my introductory to the whole exercise, and I'm ready for the questions. Thank you very much.